Professor Mahmoud Salah and my friend, who I thought it was my friend Ahmed until today. Ahmed asked me to present about Shaggy Aorta. So, looking through the evidence, there wasn't much on the guidelines. Actually, Shaggy is mentioned only once in the 3 guidelines that are published recently, and it says it might be a contraindication for fenestrated. So I went searching for more evidence to talk about Shaggy Aorta today, and I found this lovely systematic review and meta-analysis. I was only frustrated to find that they concluded that no studies were eligible for the study, so nothing to talk about. And a lovely post-mortem paper with lovely pictures, but again, nothing to say about what to do with Shaggy Aorta. So here's my Shaggy joke to get it out of the way. My, my face impression when I was asked to talk about Shaggy. Okay, so what I found is the definition was coined actually in 1991. It meant significantly extensive atheromatous disease of the aorta with ulceration and a lot of debris, but no true thrombus. It's a different name, but it's also called coral reef aorta or hostile aorta. And later on, a couple of years after the Shaggy Aorta syndrome with cholesterol embolization was coined, all the organs might be affected with the atheroembolization, but it mainly goes to the kidneys, lower limbs, of course, and the bowel, but also to the skin, causing blue toe syndromes and stuff like that. And it might go to the brain, which is the most dangerous, but the most common is the kidneys. So how much is too much? When do we call it Shaggy Aorta? You like to say that every so often when you see some very bad aorta on a CT. Oh, Shaggy Aorta, okay. So, but how do we assess that? So 3D reconstructions, volumetric assessment, and all of these are very good in giving you an idea. But is there anything subjective? Anything objective about that? So there is actually a scoring system that was devised in 2020. And it actually works by getting a 5mm cut CT scan for the whole aorta from arch down to the iliacs. And each 5mm slice is assessed, and if it fulfills the 3 terms of having ulcer-like thrombus and over 2/3 of the circumference with the debris and a maximum thrombus thickness of at least 5mm, then it's counted as a 1 Shaggy score. This is how it's supposed to look like when you're doing the scoring. And then the aorta itself is divided into 3 zones. Zone A1 to the subclavian, A2 the descending thoracic aorta, and A3 is the abdominal one. And then if you have a Shaggy score of over 10, then you know you're going to have a bad outcome and high risk of embolization. And also, if it's more concentrated in zone A2, then you have worse outcome as well. So each 1 Shaggy point increases the risk of atheroembolization by 1.13. So what are we going to do with this Shaggy aorta when we see it? So the best advice that I found, beware of the Shaggy aorta. Recurring theme, what can I do? Shaggy aorta can cause problems even if there's no aneurysmal dilatation, and there are various reports about atheroembolization to the bowel. This case reported recurrent embolization into the mesenteric vessels from a Shaggy aorta even without aneurysmal dilatation. So what can we do when we're doing open repair? Most of the evidence or the reports that are in the literature are talking about open repair in the thoracic aorta, and the standard is to have deep hypothermic circulatory arrest before touching any Shaggy aorta or atheromatous, very diseased one. And that's to avoid, of course, embolization. And reversed or antegrade cerebral perfusion isolation is also mandatory to prevent atheroembolization to the brain, again, when you're talking about replacement of the arch. In terms of endo, the only advice that I found is that if you're using a low-profile device, you might get away with less risk of embolization. And this is a study from a Japanese group, and they've looked at the results of using thoracic endografts, which are low profile, versus the regular one. And actually, one of the low profile ones was the Navion, which was retrieved from the market. But anyway, they had 35 cases of low profile versus about 300 of normal grafts, and they concluded that they had much lower mortality and overall embolization risk with low profile ones. There are some reports of using intracerebral filters and protection device when you're doing endovascular repair, again to avoid arterioembolization to the brain, and this is one of the case reports that was published. And in terms of hybrid repair, there is also one study reporting the results of open versus hybrid, and they concluded that hybrid repair did actually worse. Combining open repair with TVAR had higher risk of mortality and complications compared to open repair. For the thoracic aorta, again, open repair, there was a very interesting case report, actually two cases, where a Japanese group again reported replacement of the whole Shaggy aorta with a graft from the left subclavian all the way down to the bifurcation. And they published the pictures, but they said the exclusion technique was very simple and durable and straightforward. I don't know if you agree with that. Endovascular is, of course, TVAR that we spoke about. And in terms of abdominal aorta, there was an interesting case series, or actually a comparison between EVAR and open in Shaggy aorta versus normal aorta. Again, they use the liberal definition of Shaggy aorta here, but 400 repairs versus about 50 in Shaggy aorta. And again, they found that the risk of mortality and overall embolization was worse, definitely, in the Shaggy aorta compared to normal one, but complications were much, much lower in the endovascular repair of the infrarenal abdominal aortic aneurysm compared to open repair. So I have I found a couple of cases that I could present to you from my own experience. This is a lovely 59 years old lady who's a smoker, hypertensive, presented to myself with Bluetooth syndrome that has been there for 2 weeks. Her workup showed positive ANCA antibodies as well, so a bit of prothrombotic patient. So this is her pre-op CT scan, and thoracic aorta is not too bad, but when you look at the abdominal aorta, there's a lot of thrombus, and there's kind of a saccular aneurysm full of thrombus. Now, it's not up to 5 centimeters, but it's manifesting with this Bluetooth syndrome, and the consensus was to treat that with endovascular repair. And I ended up inserting an Endologix graft because of the tight distal bifurcation. And of course, also because it's a low-profile device, as Professor Mahmoud said, they are lovely to do percutaneously. And her follow-up CT scan on your right-hand side a year later showed significant regression of the sac and very good remodeling. She was also on anticoagulation because of the positive ANCA. So not all of the thrombus in the CT scan pre-op was debris. It might have been actually a true thrombus. The second one was a 76-year-old gentleman who is also hypertensive, ischemic heart disease, previous coronary stents, and he presented with a rupture AAA. So this is his pre-op CT scan, and it's one of the worst that I've had to deal with, to be honest with you. And as you can see, the aneurysm could be classified as type 4 thoracoabdominal or just pararenal, suprarenal kind of thing. So I ended up doing open repair for him with reimplantation of the left renal artery. This is a CT follow-up about 4 weeks later. He did okay. He had a long stay in the ICU, probably about 2 weeks. Started improving. Started talking, eating, and unfortunately, he kept aspirating. Now, after the scan, after the repair, as you can see, there's a lot of thrombus. It actually got worse in the thoracic aorta, and he ended up embolizing into his liver, spleen, including his right kidney as well. And the only thing that didn't embolize was his bowel. But his chest was very bad. He aspirated a couple of times and ended up with very bad chest infection. And after he was discharged to ward level, unfortunately, he didn't make it out of the hospital. So he RIP'd about 10 weeks later. So this is all what I have to say on Shaggy Aorta, and I hope I've changed your picture from this into this. Thank you very much.